Good morning, class. Welcome to lecture on the skin. It's an important one. Patients will come in with things on their skin, rashes, abscesses, cuts, warts. I think it might be melanoma, all kinds of issues there. Something that they notice more than they can't really see their kidneys or their liver, things like that. So we'll build a vocabulary to start talking about skin issues and how to describe them, because there's a bewildering array of ways to talk about particular. Is it a rash? Is it a hive? Is it this or that? So get to that, and so yeah, let's just get right to it. All right, the skin, and it is your largest organ. I talked about the liver being the largest internal organ, but in terms of sheer size, is about 2 meters square. Would be if you spread your skin out like that. And very important for one thing, your temperature, right? You being able to shunt blood to your surface is a way to lose heat, and especially if you add that with sweating. Indeed, and most importantly, it's the big waterproof barrier between you and the environment. And you know how important it is when you lose a bunch of skin. Anything over 20% of your skin, you're put into a special, burn unit type of environment where everyone is completely sanitary, because you know how important the skin is for keeping all the bacteria and viruses and fungi that would love to live in you. Your skin is this great barrier. It's got this layer of dead protein, this keratin on there, and it grows from the base outwards. So anything trying to get into your body has to kind of swim against the current. So your skin is always being replaced, and it keeps, without it, you lose tons of water as well, right? And a major sense organ, indeed. Think about the fingertips, all the lips and other sensitive areas, all the nerve endings there, and all this pressure sensors that allow you to observe the environment and temperature and texture. Yeah. And also vitamin D production. It's important that your skin gets some exposure to sun so that you can convert a pro-vitamin D to a more active form using sunlight. So just reviewing, you guys remember skin, the epidermis is a really thin layer. It's a very actively dividing tissue, stratified squamous epithelium, where the basal layer has the stem cells, and they're always dividing. And as they move up, the keratinocytes, the spiny, prickly cells, the cells start dying. They start getting thinner, dying. They start building up this protein keratin. By the time to get to the top, they just jettison all their mitochondria and Golgi, and they just die. And they end up being this cornified layer on the outside, which is the layer that sloughs off. The dermis is thicker and tougher. It's got tons of collagen fibers and elastic fibers. And that allows you to, your skin snaps back when you pull it out. And as we age, that gets thinner, and the elastic and collagen is damaged by decades and decades. And so if you pull the skin back on grandma's hand, it just is kind of very thin, and it doesn't really snap back because of all the age, what it's done to that elastic fibers. Yeah, really tough. And all those collagen fibers, that's what makes leather. You think about leather belt, leather shoes, that is the dermis of a cow or some other animal that we use. So gives you an idea of the toughness of the skin is from that dermal layer. And then the subcutaneous layer is mostly fat. That's under your skin. You have a layer of fat. Then there'll be a membrane before you get to the muscles, which would be enclosed in their own membranes. And you hear about ways of giving drugs. You can have an intradermal shot. Just talked about doing the TB test. Just kind of put it right under there, or a subcutaneous, or why we have a hypodermic needle is because the needle can get into the hypodermis, this fatty layer beneath. And the accessory structures of the skin, like the hair and the sweat glands, they all arise from that epidermis, but they dive deep. And some hair follicles will be in the dermis or even into that subcutaneous layer. They get down that deep, but they come from the surface. A little closer, looking at the epidermis. From the bottom, this basal layer, often kind of cuboidal cells. And these guys are really actively dividing. They're going through mitosis constantly because you know how tan fades. It's because in 30, 40 days, something like that, the basal cells have made their way all the way to the top, and the melanin you had deposited in that tan is eventually will be sloughed off with this keratinized layer. But the layers, you have a basal layer, the spinous layer, then it gets, just before it dies, it accumulates a bunch. It really stains well because of all these accumulations of these proteins like keratin that it's making, and it's getting rid of the nucleus, everything, and then it's just flattened, and then the keratinized layer just sloughs off. And then different parts of your body is different. The soles of your feet and the palms is really, really thick layer, and that you can see this hanging from his back, just showing you how tough that dermis really is. And then it's thinnest in your eyelids. So our skin varies quite a bit. And then you look at the distribution of nerves too. It's amazing. It's so many on the lips and the genitals and your fingertips, and so few on your elbow and your lower back. And so, our body is, and then how much of our mind is devoted to that portion of the skin. It has to do with where we need to sense things and where it's not as critical. Just a beautiful histological slide of a palm or sole. You can see all of this is dead cornified layer. Gorgeous. And here's the dermis down here. And you can see it meets, it's called a papillary layer, right? It doesn't meet face to face, but it's like complex. So there's less shearing going on. Yeah, and this, I can even see here some of these little corpuscles, or tactile corpuscles there. When you look at the, into the dermis, it's, what kind of epithelium, connective tissue that is. It's a dense, irregular, so it goes in every direction because you can pull your skin in any direction. And then I'm looking at the layer of the living cells, and then the cornified layer. See the stratum granulosum. Anyway, this is a beautiful histological slide. And also, remember, these bed sores are, if you, there's no blood vessels in the epidermis, so the blood all comes into the dermis where it gets close to the epidermis. And if you have constant pressure on your skin anywhere, it's going to keep the blood from reaching it. You'll have, it'll necrotize and it'll die. So patients that can't move or in a wheelchair, you need to make sure you massage and move them so they're not constant pressure on any one body part. All right, the melanocytes, so what make melanin, this dark pigment, which is going to protect your cells from UV radiation. So if you look at the basal layer, and if you're a really good histologist, you can pick out the melanocytes. They look a little different. And they kind of have these arms like an octopus. And when the UV radiation hits them, when you're out in the sun, they will produce melanin. And the melanin will go up these little fingers and be injected into the nearby cells. And those cells are on their way up, right? And so that pigment will help block the light so it won't cause DNA damage to those important basal layers. So melanocytes are involved in protection from UV radiation to protect from cancer. And looking at people of different darknesses of their skin, they all have the same number of melanocytes, but there's more active or not. And there's some difference in the melanin granules being a little different sizes depending on darkness of your skin. But we originated, human beings, in Africa, and then we moved out throughout the world, and we're darker. Now, as you move up into north to Finland, etc., the days get shorter, or in Maine, right? The days are shorter, we have less sunshine. And so probably this loss of melanin allowed us to have enough vitamin D so we didn't have rickets and other problems, a lack of calcium. So that's the idea. And if so you look at the world, the darkest people generally with the most amount of sunlight, because you have those competing variables. You want to block the sunlight or you're going to have skin cancer. But if you are really dark and you move up to northern Finland where there's very little sunshine, you're going to have vitamin C, calcium deficiency. So, right. So we straddle these two things with our skin tone. Yes, so the dermis, when you look at it, it's lots rich of collagen, which is super tough protein, and elastic fibers. And then in there, you'll see from the epidermis, you'll have sweat glands, eccrine sweat glands that make sweat. A lot of them on our forehead and our back and places, and that's going to make sweat, which allow us to cool off. And then apocrine glands are sweat glands that are found in our armpits and in our groin, some around the corners of our mouth and our nipples that secrete a little different kind of substance, not so watery, it has more protein in it. And these come alive in puberty, and some of those proteins, they'll degrade, and so there's an idea that they are used for mating and for giving off a scent. Think about underarm odor, you think, try to get rid of it, but really, probably some of that scent is involved in letting other individuals know about your sexual status and things like that. Yeah. Some of these make really odoriferous secretions and moving on to other kind of animals and stuff. But anyway, yeah. And just to remind you, when you look at your skin and the dermis, it looks like the collagen is going every which way when you look at a single slice. But if you take a big picture, there's general kind of a weave like you have in fabric to our skin. And so when you make cuts, if you don't want it to gape and to scar, you cut along those lines. So there's these lines in our skin that are subtle when you look at a small little piece of skin. But if you step back, it's like there's an overall kind of texture to our skin. It's important to know that if you want to not go make incisions against that, so it would gape more. And blisters, it's actually not in your chapter, but the dermis and epidermis should meet nicely like this, like two egg cartons. So there's not a lot of movement. But if you continue to have that shearing movement, you get those new hiking shoes you never worn before, and you keep moving your skin, you will eventually break that down, and fluid will seep in, and that'll be a blister. So epidermis and dermis should be a tough connection, and it moves together. But if you really push it, you can cause a blister. All right, and so in the some accessory features are like hair. Ask my brother Steve, and I got more hair. It's genetic, it's genetic. But a hair goes through periods of growth, and it'll grow and it will not grow, and then they fall out, the follicles, a certain percentage. But in us, it happens not all at once. Like some birds will molt, and you'll see birds all like down, like, and get all their new feathers. It's a continual process where hair grows and has these periods of rest as well. And then sebaceous glands are connected to hair follicles. They make sebum, kind of this, makes your hair oily. It's a bunch of debris and lipid-rich substances that give a oiliness to our hair and help protect it. Yeah. Another thing about our skin, we talk about medications and such, that you can give patches. You can have a transdermal application of drugs. And so most famously is nicotine patches that deliver nicotine if I'm trying to quit smoking. But birth control, like that. And I cannot attest to whether hangover patches work or not. So I saw this online, and anyway, just thought I'd show you another application of applying something transdermally. And I thought I'd throw a slide about tattoos. The reason they're permanent is they're not in the epidermis, because that is always sloughed off. So you take pigment and you insert it into the dermis, and your body will have an inflammatory response, but hopefully, the pigment will stay there, and the epidermis will, you'll have a scar on top. I have no tattoos, strangely. Epidermis will have a scar, how that kind of happens, and then it heals, and then that pigment remains in your dermis for decades, long time. It can migrate a little bit deeper. And if you want to get rid of it, you have lasers that go in to break it up into small pieces so it can be engulfed. So tattoos, how they've changed, from sailors and prisoners, and now everyone's got tattoos. All right, let's get to the issues, most common issues with the skin. So cuts and abscesses, pretty straightforward, right? And then acne, talk about that. Moles, nevi, little moles, verrucae or warts. So moles and warts are different. And then kinds of dermatitis. Dermatitis just means inflammation of the skin, but there's eczema. And then other kinds of dermatitis like dandruff, kind of sloughs off. And then rashes can mean a lot of things. Take a look at that. And then we'll look at these little actinic keratosis, little sun damage that could turn cancerous. Yeah. And then, of course, the most life-threatening things are burns when you, or there's on a motorcycle, if you were to be wearing shorts and to slide on the asphalt, you have this degloving where skin comes off in large patches, and incredibly painful, but also very dangerous because they really worry about you getting infected there. And this one, you can read about this, is toxic epidermal necrolysis. You get a drug interaction that causes your skin to slough off. So rare, but really, really a bad thing to have. Sure, so they look at percentage of body surface lost to see, and burn units will be in major hospitals, not all small hospitals will have a burn unit. But in there, they're going to be, everything is completely sterile and no visitors unless they're all cloaked up, because you've got open skin. It's just perfect for infection. Yes, so some skin lesions tell you, is a good clue about diseases, right? If you got chicken pox or measles, or smallpox anymore, but it's going to obviously be shown in your skin. Yeah, and this kind of a rash is characteristic of the certain type of lupus, and so it kind of shows up, and it has you look for this autoimmune disease. Yeah, gout is too much uric acid, and that will sometimes come out in the skin, and the fingers, other places where you'll have a little. It's the uric acid itself, so kind of substance there. Diabetes often cause skin issues, lower limbs, kind of patches where the small blood vessels are being affected. You'll have dark patches. There's some disorders with hyperlipidemia. Too many fats will cause kind of a yellowish, greasy secretion from your skin in certain places. And then pregnancy. I talked about how areola darkens with pregnancy, and sometimes you get this melasma, particularly on the face. It can be disturbing, where this dark patch or dark patches or darkness will occur. You'll see changes in the skin, and sometimes the midline and the abdomen in a woman. And so melasma is kind of, it can happen for other cases, other causes, but the hormones will cause it to happen. Other things will cause this to happen, and it's kind of a mystery and hard to treat, really. And then skin cancers, non-melanoma, like basal cell and squamous cell, are much less dangerous than melanoma. And so much so that these cancers we spend a lot of time looking at the most dangerous types of cancers, and they're not even on there. But these skin cancers are more common than the other cancers, but it's not on our list because they're rarely malignant and cause too many issues. Now, melanoma does make the list. It's up there. It's number 5 up there, number 6. I don't know. It's up there. Melanoma. If the melanocytes get cancer, as opposed to just one of the other basal cells, it just happens to grow really deeply and tends to invade and go to other places in the body. So for some reason, when melanocytes get cancers, they tend to be malignant and really bad. The other skin cells tend to just stay local. In all these skin cancers, of course, sun exposure has been a risk for all of them. Yeah, all right. So first of all, person coming in with some kind of skin issue, usually it's disturbing, acne right in your puberty years. Who wants that? You're trying to make an impression on suitors, etc. And moles, things, especially when they're on the face or the hands, they really are disturbing to people. And then itching, pruritus is a fancy word for itching and pain. Can be part of these skin issues, definitely. And it may be obvious where it is, but if it's also important to check everywhere in a patient, because here's one mole between the toes. Ticks too, they can hide deep in your belly button. So when you look at skin issues, when you want to do a full checkup, you look at the gluteal folds and the perineal region and between the toes and in the scalp. So just realize that it's not just the skin you can easily see. And people will come in if they notice one on their arm or their face, which they look at a lot, but they may not see the back of their neck or their ear or something like that. And usually relatives or friends would hopefully point that out to them. So how do we describe these things? Look at oh my God, there's so many descriptors. I got this little thing on my hand, how do you describe it? There's so many ways, but you can look at these pictures and get an idea of all the variables that you could describe these skin issues. But definitely the size, you know, where it is there a whole satellite of them or just one? And then color, is it uniform? They could be pink or black or everything in between. The edges round, or are they jagged? And is it raised, or is it just smooth like the skin? So let's get into some of this vocabulary. Yeah, so here's a bunch of words, and hopefully you get it. Macula means spots. The macula in your iris is that spot in the middle. The spotted salamander here in Maine is Invistum maculatum, the yellow spot, because that's a spot. So a macular lesion is just a spot that's just flat. It looks like skin, it's just not raised. Yeah. When you hear a papilla, papilla, a little papilla is a little raised part. And a rash is usually found in parts of your skin. It's usually temporary rash forms, and could be from various reasons, but you all know what a rash is, right? And rash, there's a child with measles, you know, showing a big rash. This could be contact dermatitis, maybe, not actually sure. But rashes, usually it could be some kind of systemic infection like measles, rubella, rheumatoid fever, a lot of things, you know, chicken pox cause these things. Hypersensitivity, so you could get a rash because you ate shellfish or you had some kind of reaction. Yeah, or local contact. So you get some earrings that you'll have a rash, a reaction to the metal, something like that. Yeah, so a macula is a spot, and so you'll see these spots that are not raised, but sometimes they can be large or small, but there'll be these spots that are just pigmented areas of the skin. And a patch is if it's a big one. Patch is if it's one of these maculas is quite large. And here's some papilla on this patient's nose. They're raised. Now a plaque is going to be also raised, but it's in a big flat area. Yeah. And a nodule, you can see this kind of thick, solid nodule can form. And if you hear about a pustular abscess, it means it has pus in it. Right? And oof, look at these blisters here. So vesicle means it's filled with fluid. A bulla, also same thing. This can happen in burns, poison ivy. These vesicle or bulla are little like that. And hives, some of you are familiar with hives, or a wheal, are these parts of your skin that are raised because of edema. So usually histamine is being released, and there's like raised areas. So you know you get these hives that usually come and go. Right? A scale, you could imagine scaly, like it's part of the skin is coming off. And if there's a crust on it, that's that sebum from the plasma. It's kind of this yellowish crust that you kind of just want to scrape right off there. So it can be crusty and scaly lesions. So what do you want to do when you find one of these? There's a mole. It could be just cosmetic. You want to get rid of it, or you could be worried about it because it's irregular, it's getting bigger, things like that. So excisional biopsy is when they take out a piece. Usually there's a scalpel, they got instruments to punch out a piece. They want to get enough of it so that in case it spread, so they want to take out a piece of it, and then you know, they'll close that up. And then they'll send it off to the lab because they want to take a look at that to see if it is cancerous. And if it is, they find it's a melanoma, they want to see, well, do we get deep enough? Do we get enough of it? And then should we check lymph nodes, right? And often that's the sole treatment. If you've got a weird mole, they'll excise it, or they'll burn it off, liquid nitrogen, they'll get rid of it, and then, yeah, you're done. For skin tests, you also may want to take a culture to see. You could see, see if it's some kind of fungi growing in there, what kind of bacteria, it's staph or things like that. Yeah, if it's a fungal infection, they need to look at a microscope and stain it to see is there fungi in the epidermis. And then, you know, if you have an overall rash, maybe do a blood test to see if you've got measles or something. All right, let's talk about some things. Here are some things, some kind of congenital things usually. Hemangioma is going to mean blood vessels. And so you have the blood vessels that are growing so much, way too many blood vessels, they make these reddish marks on you. And sure you're all familiar with port wine stains. You'll see often it's pinkish even in birth. This stain, it can be alarming, but it's not really dangerous. With age, it turns usually darker. It could be turned purplish and darker red. but it has to do, these are all capillary malformations, where way too many blood vessels grow for some reason in certain areas. Hair disorders, alopecia, early onset baldness. Mostly it's a man thing. It's X-linked, but women can also have this as well. But it's caused by many genes that are involved with this baldness. And I've talked about hirsutism, having usually it's too many hormones, androgenic hormones, testosterone type hormones, that causes excess hair growth. Albinism. There are albinos with that lack pigment, and so they're very sensitive to the sun, and especially when you look at the iris, even if there's no pigment, you want to wear sunglasses so you don't have damage to the retina from too much UV radiation. But very uncommon, albinism gene, autosomal recessive, and there's just making melanin requires several steps, chemical process with several enzymes. And if you don't have the right enzyme, you can't make melanin, and you become albino. There's albino crows and bears, and it happens snakes everywhere. This pigment, making the pigment, there's several steps. Like I say, it's easy to interrupt that. This is an interesting condition here. I studied this with when I taught about DNA repair, and this xeroderma pigmentosum is a disease where the person can't get out in the sun, because if they get out in the sun, they get tremendous skin damage. And it just really, this is a good lesson that the sun causes damage to your DNA all the time in your skin, but you have repair mechanisms that will get rid of those cells that are screwed up. Now, in this disease, they don't have the repair mechanisms to DNA. So the sun does the damage and they show it. And so they show all kinds of skin issues immediately. You can see some pictures really, really bad if you go out in the sun and you have this disease. You and I are having the same damage. It's just that our DNA is we have the ability to repair it, and so we don't see as much damage. So you can see these, if you have a kid, they can't go out and play in the sun. They need to be protected from UV lights, cover windows, no problem at night, but during the day. All right, so I'm going to get to a bunch of diseases now. A lot of things will have skin issues. First of all, chickenpox. I had it. My brother and I had it. We were kids flying to Brazil. Unhappy to kids with chickenpox, but now we have vaccines. So I don't know if any of you guys had chickenpox. Maybe not. But it's a virus, varicella zoster virus, and the virus causes all of these pustules. It's usually not a problem. If you get it as an adult, it's much more serious. But as a kid, got chickenpox, it lasted a week or two, I don't know, and then you get rid of it. And then turns out you still harbor the virus, but you don't get chickenpox again. You don't get this obvious thing. But that same virus can pop its ugly head up again in later life, usually when you're in the 60s and 50s, 70s. And it's called shingles. It's the same virus. So this virus had resided in these nerve cells. And for some reason, they wake up and they travel along the nerves, and it causes horrible, painful rash. And you'll see it. It's a good way to see, to teach about dermatomes, how each nerve goes to a particular piece of skin. So it often will wrap on a particular piece of skin on one side or the other, where that virus woke up and caused all those issues. There's a vaccine, new one, Shingrix, you can get when you're 50 against this. But shingles, usually old people, a very painful rash. Yeah, so it's caused by a virus, and exanthem is a rash related to an infection. All right, warts. So warts, verrucae, special name. You have the verruca vulgaris is the common wart. Usually on your hands or your feet, can be other places, but it's a hard, raised, dry lesion like that. There's a verruca plana, it's a flat wart, and it's often it's not as raised, it has the same color as the skin usually. You'll see these sometimes in rows, you'll see these. And then we talked about this in an earlier lecture on genital issues, but HPV, the condyloma accunatum, is warts, genital warts that form genital anal region or the mouth region. So these warts, yes, you don't get them from toads. What you can do if you have these is just live it up, but you can also, they normally will freeze it off with liquid nitrogen. So extreme cold will cause that area, the skin will be frozen dead, and then it'll turn black, and then it'll crust up and fall off. Or they can cut it out. They can excise it, and that's one way of getting rid of it. And one problem, that's a little issue getting rid of warts, is if you don't get it all, it often, that the virus that causes it will be in cells nearby. And so you may get the wart, you think, but if it's nearby, it'll come up again. So sometimes they'll reoccur. And this shows the normal verruca vulgaris warts here. And then here's more the genital warts. You can see that. All right, acne. Acne is something that's obviously not deadly like that, but if you have severe acne, it can be disfiguring, and especially if you scratch at it and it gets infected, and it can cause lifelong scars on your face. But it occurs on the face and on the back, and especially at the time of puberty when there's a lot of hormones coming out. And it comes from blocking your sebaceous ducts. With each hair, you have a sebaceous glands that come out. And if that gets blocked, the sebum builds up, and then it can be infected by bacteria, and it bursts, and it causes inflammation, turns red, and yeah. So these comedones are a fancy word we call for acne. And yeah, you can see blackheads, the top is usually open, and that sebum reacts with air and turns kind of darker. And then whiteheads still have kind of a surface on them. It's just the white pus that you see underneath it. Yeah, but yeah. And it comes just as you're trying to get men or women interested in you, your appearance becomes important, and then you get this acne. So it's really kind of cruel, isn't it? But it's usually, like I say, you have it when you're younger, and you grow out of it, usually. Yeah. So this bacteria and other bacteria can grow in your skin like that. Definitely. Yep. Cool. You can take a look at this. You can see, okay, yeah, acne. And people vary. Some of it's we got genetic. You'll see, certain families that get more acne. Others have perfect skin, right? I hate those people. Kidding. Yeah, and so you'll see it's not caused by chocolate, other ideas. It is going to be this blockage. I'll talk about what we can do to prevent it. Yeah, but mainly it's the washing. You get astringents. If it's serious, go to a dermatologist, and they can give other drugs. I mean, steroids are serious if you want to reduce that inflammation. If there's a really big problem. Other kind of other drugs are available, and antibiotics, of course, would help with the infection. So mainly just keeping clean, ride it out, and then see a dermatologist if you're really concerned. And they have more up-to-date options and can elevate your attack on it. All right, an abscess. So working in healthcare, you're going to have abscesses. You're going to have these skin infections in patients that can vary in size. We'll talk about it, but you've got pus in there, which remember is the neutrophils and the decaying tissue broken down. All that turns into this yellow pus. So yeah, skin trauma. It could be if you have a splinter kind of thing, abscess will form around it, and around hair follicles. You'll see it starts with that sebaceous gland, and that inflammation grows. Yes, so what happens around the nails, very common, parenchyma, and pilonidal cyst. I looked that up to try to practice that. Pilonidal cyst, that happens up here above the gluteal folds. You'll have I mentioned earlier, you'll have an abscess can form there if fluid get caught. Right above the gluteal region can be painful. Yeah, and abscesses around back in the neck, on the anus. Yeah. Well, a boil or furuncle, a fancier name for it, is looks like a larger acne. Yeah, type thing, and you can see that it's no problem if it is contained. Like I say, your body will kind of wall it off. And we'll talk about, you can incise it to release the fluid. And as long as you don't introduce bacteria and it gets more infected, you should be fine. Yeah, so you can see here a big abscess. If it's a big abscess, you do want to drain it. I mean, wearing gloves and make sure you're not introducing any bacteria, but drain it, clean it out. Sometimes you'll do a stitch, something to keep it, things from getting in there. It should heal. Sometimes it takes a long time. Carbuncle is a bunch of furuncles, so it's kind of a bigger area where there's multiple guys involved here. And so, yeah, back of the neck, it can happen. Yeah. Look at my face. I just think whenever I'm looking at abscesses, like, oh, yeah, it's kind of. All right. Impetigo is something usually kids get these. It's a staph infection in the skin, and it kind of crusts over, and it can be spread among kids that play together. Yeah. So impetigo. Maybe you look at your kid in daycare, things like that. It's something that it's quite common. And syphilis, we talk about this with male and female reproductive. And so this is just review, but the chancre, kind of a sore that happens, and it can happen in the vagina. You might not even notice it. It's not that painful. Caused by a spirochete bacteria, syphilis bacteria. And this will occur and it will heal, but you still have the treponema bacteria in you. And so secondary stage is where you see the skin rash. And you see the soles, palms, that can be all over. So if you see a rash like this, could be syphilis. And then even penicillin, as old as antibiotics, still works on this. So you'll be able to get rid of it. And if you don't, then it can go, syphilis can travel to the brain and heart over decades. So, you know, hopefully you catch this, get some penicillin, you'll be good. And of course, it's an STD, it's contagious, right? All right, let's talk about fungal. Sometimes fungi are hard to get rid of in the skin, you know? You get fungus under a big toe or something like that, and boy, it's hard to get to. There's some expensive creams you can put on top of the nail that can penetrate in to get to it, or get some other creams, but you know, it often hangs on a long time. And athlete's foot and jock itch, all these things are ringworm or fungal infections of the skin. And when we talk about the skin, it grows only in the epidermis. This is a great histological slide showing. So you'll take a biopsy and you'll see hyphae and spores of fungi eating away, growing in the epidermis. And the two main types of fungal infections are ringworm, it's not really a worm, but call it tinea, all kinds of tinea, and then candida is another kind of fungus that grows. We talked about it causing thrush, or in the vagina it can grow. So ringworm, it forms these rings. It's not a worm, it's a fungal infection. Terrible name. And these little patches can be found anywhere on your body. Like what is that? It's kind of this round thing. It doesn't necessarily itch, maybe even, but it'll be ringworm. It'll grow, and it's hard to get rid of. You need creams that takes a long time because fungi don't have a lot of good drugs for that. It's a different animal, definitely. And you can get ringworm from your dog. You can give it to your dog or cat. So ringworm can be between animals, between people. All right. So tinea, various kinds of tinea. We have different names for it. Like if it's on your feet, call it tinea pedis, athlete's foot. Crurus, jock itch is your crura, the legs are there. Tinea capitis on your head, right? Tinea barbae in the beard. And you'll have that grow, and often the hair will fall out, will be killed, so be kind of patches there. Yeah, but this tinea is common fungi that exists in our environment. So you'll get it, like even if you touch a dog with ringworm, you're not going to get it automatically. But if you have cuts or you have psoriasis where there's openings, then it can get into you. So, you know, you scratch your head, you get a little cut, and then it's susceptible to this fungus getting in there, and then the fungus can take hold and grow in your epidermis and not cause necessarily a lot of issues, but can cause itching and other issues that you want to get rid of it. So yeah, you see some antifungals. So Candida albicans is a fungus that's found everywhere. It's growing on your body right now. I don't even think of yourself, not my, I'm clean. No, you got this fungus. It's all over the place, and normally it doesn't cause a problem. It's just commensal. I mean, it lives with us. It doesn't cause any problems. But it can wake up and it can cause some real issues, and it can gain entry into your skin, under your nail, and this fungus can grow. Usually moist areas, you see the chest region, even men and women, but under the breasts, kind of areas a little moisture, or underneath the arms, or in folds if you're obese, things like that. It can take hold, and you see this skin infection, and it's caused by this yeast, and you want to get some antifungals. So it can cause some itching. Yep. So definitely, if you're on immunosuppressive or antibacterials, as I mentioned, that candida in the vagina. Oh, okay. Vagina happens when you maybe take antibiotics and it kills off the natural bacteria that keep the fungus at bay. Or thrush, when this fungi gets in your mouth, it gets all this bad odor and this kind of whitish substance in there. It's going to be that. When you're immunosuppressed or you're taking a lot of antibiotics, it can happen. Places that are moist, if you bartender and you're always working in the sink, you can get it on your nails, things like that. Yep. And diabetes too. All right, enough of the fungi. So dermatitis, derma is skin, right? So it's an inflammation of the skin, and there's lots of causes of dermatitis. So caused by drugs or allergens, sunlight, if you have a sunburn, right? Definitely. Trauma and immunological disorders, definitely. So you can see dermatologist appointments, some kind of dermatitis, and they want to see what is it, how can I get rid of it? So acute dermatitis. And the deal is really that they don't always, it's hard to tell exactly what it is that's causing this dermatitis. It doesn't matter if you're just treating the symptoms or what actually caused it, but unless the cause can be avoided. And so if they can look at your history, what have you touched? What have you done lately? Has this been recurring? They can use those clues to figure it out. But even, you can see histological features, even looking, it's not really, it just shows dermatitis. It doesn't really give you the cause as well. So yeah, but they can figure it out, looking at various clues as well. And so you can take a look at this contact dermatitis, usually where you had contact with it, in a certain patch or an earring, you can tell that. That's the most common. Dermatitis is contact. But atopic, remember, like we talked about hay fever, allergic rhinitis, or eczema, or did I mention hay fever? Yeah. So these things, these kind of diseases are caused by some kind of allergen. It doesn't have to be where it was touched, but it can be, an overall kind of thing. Yep. Light induced. And then this exfoliative one, maybe a reaction to some drug, can make your skin fall off. Don't mean to scare you, but it's pretty rare. So contact dermatitis, definitely. So this person had a nicotine patch, and pretty obvious where that dermatitis came from, because it's the shape of the patch that they had on there. And I show someone with allergic to some kind of metal and some cheap jewelry or something like that. Yeah, so it's pretty obvious there. So the causative agent can be figured out by what has been in contact with that particular area, right? You can test for it. And poison ivy, I'll talk more about that. I'm really susceptible to poison ivy, and luckily moving from the Midwest, I haven't gotten it. We have it in Maine, but I haven't gotten it, but I used to get it when I was in Iowa. I would radio check rattlesnakes, and they would be in poison ivy. You try to avoid it, but you just can't. And then it gets on clothes, and then it touches your skin and just causes this horrific reaction. It's an oil in the plant, urushiol, that gets in your skin, changes a protein, and then your body has an immune reaction against it. And it makes this lasts for weeks, and it's just weeping and just horrible. So the plant looks like this. I'm very familiar with it. I can point out to you if you want to see some. So it's obviously not evil. It's the plant is doing it. It's just chemical warfare, right? It's not the thing. And it turns out that some people are very sensitive to it. Some people are completely immune to it. And then people are in the middle too. And there's some idea that if you keep getting exposed to it, you get a hypersensitivity where you become more reactive to it. So I don't know about you guys out there, how many of you have ever gotten poison ivy? I think in Maine, most of you are going to say, no, but some of you have. And you can get it, and it can spread to your genitals. Never had that problem, luckily. Horrible, or if you burn it, even cause like serious reaction in your lungs. So this oil urtiol is very nasty stuff. And so it's also hard to do anything about it. So even if you take a shower immediately, once the oil gets in your skin, it binds the proteins and you just can't get rid of it. But they do have some products out there, newer products, you can kind of scrub it off. And hydrocortisone will bring the reaction down, or antihistamines will help. Yeah. But if they had a vaccine, that'd be great. Imagine that. And it's not unheard of. I mean, they should be, they're working on it to be able, so you don't have that reaction to this oil for some people. Great thing. Just an aside, mangoes are in the same family. So sometimes the skin of a mango will cause tingling. Yeah. And rubber tree plants too. All right, atopic dermatitis. And atopic means you have some kind of an allergen. You react, you overreact to something in the environment. And the reaction doesn't have to be at the spot. It can be many places. So that's the idea here in eczema, in the hay fever. This is the idea people have allergies. And a lot of this is not known why some people have this and some don't. You can see some genetic basis, definitely in the environment. Talk about that hygiene hypothesis. But eczema, people with eczema, they are reacting to some kind of allergen. And eczema, you can see terrible here on the child, but often on skin looks kind of has plaques on it like this. Yeah. This type of dermatitis, seborrheic dermatitis, sebaceous glands, they will give off a lot of sebum. It's this cradle cap where you see this kind of yellowish, because there's a lot of sebaceous glands with hair, like in the scalp here. So you have kind of a yellowish kind of sebum, kind of like, fatty, kind of yellowish secretion. Yeah, I love the name of this particular fungi, Malassezia furfur. That's a good one. We thought about naming our cat Malassezia. It's kind of cool. All right, hives. Urticaria, fancy name for hives. And those of you, I think you're familiar with hives. You'll have these wheels, these kind of raised lesions that usually as these come, you get hives for a reason. You ate some shrimp and you had a reaction to it, and then they go away. So antihistamines will definitely work because that's what's causing the edema, is the histamines causing the fluid buildup. Yeah. So hives, you need to look at what is the cause, because there can be other causes too, besides an allergen that you're aware of. All right, psoriasis. Now psoriasis is the skin actually is it's overactive. It's dividing really rapidly, and so the skin on top of it becomes red and raised and kind of a silvery kind of look to it. Often on, see the back of the arm or the knees, you'll see this quite a bit there. So psoriasis, chronic inflammatory disease of the skin. Again, one of these things that's what exactly causes it, we don't know. It has some kind of genetic basis. And so, yeah, psoriasis is a large problem for some people, and there are some treatments. And lastly, let's look at some neoplasms. And probably when you saw the skin chapter, first thing that came to mind is moles and possibly skin cancer. So our skin is exposed to the environment, especially UV radiation. And if you're a farmer or you work on a lobster boat and every day you're exposed to bright sun, it shows. Your skin, deep wrinkles and discolorations. You know, you've lived a life out in the environment, right? Remember the Victorian days, being fair-skinned, it was meant that you didn't have to work. You were like a higher class, and you'd have a parasol and have very light skin. And now, you know, beauty, often looking at being tan, you know, and it's looking at a healthy look. So definitely, there's been changes in society about what is found to be beautiful. Anyway, so. Causes, of course, sunlight and age. Those are the two big causes of these neoplasms of the skin. And it usually involves two lines, the melanocytes, melanoma, that's the bad one, and then the keratinocytes. It can be basal cells or squamous cells, but that's what we're talking about here. You can have some rarer ones where some of the glands, can become neoplastic, but these are the two main groups. All right, solar degradation, and you'll hear actinic keratoses. This is sun damage. And so you look at skin that's been, exposed to the sun for so long in old people, and you'll see the sun damage. You know it when you see it. And what's happening is that the collagen and elastic fibers in the skin are just broken down over time. And in elderly people, that's what causes wrinkles, is a thinning of the skin, a thinning of the dermis, and less fat is going to produce thinner skin that the wrinkles are going to appear. So you'll get like fat and collagen injections to plump it up. That gets rid of the wrinkles, but it's that thinning and damage to the fibers of the skin over a long time and with sun exposure that causes damage to the skin. Yep, skin atrophy. Lentigo, you'll see in older people sometimes these patches, colored patches, small blood vessels can cause really dark little areas. And these keratoses, I talked about these keratoses. These are patches of damaged skin. These ones can become cancerous, so we'll talk more about it. Right now we're talking about it, yes. So actinic keratoses. So these are going to be, again, more likely in fair-skinned people in places that are exposed to the skin. You'll often see these skin neoplasms in people that are outdoors a lot in the lower lip or the ear, the nose. These are places, that get the full brunt of the sun because of the most damage. And so you'll see, the keratin will often spread. It's going to be these sun damage that you'll see. And they worry about these because in rare cases, these can become cancerous. So actinic keratosis is going to be taken seriously because there's that chance that it could spread. Seborrheic keratosis, these are caused by melanocytes, and they make these kind of dark lesions that can actually be scraped off. So keratin forms, that's why they're dark. We're not worried about, but these people sometimes, depending on the person, fair-skinned people will get these kind of dark little bumps that come off. All right, and these things, I got these little melanocytic nevus. So a nevus is a little mole. And sure, it's a neoplasm, but it doesn't mean it's cancerous, right? So you have little moles. And these little guys, they begin at the junction between the epidermis and dermis, junctional nevus. And then they can migrate into the dermis, and then compound nevus if it's really a thick one that goes through all the different layers. And people get these little dark spots, often in childhood, and then they disappear, or fair-skinned people will have them. I see a couple of dots there. And they can be different colors, of course, depending on your skin tone, definitely. And freckles are a little different. Freckles are not nevus. They are skin patches caused by sun, and of course it's genetically linked. It's close to the gene for red hair. Often red hair and freckles often go together because they're close. They're unlikely to be split apart and crossing over. So it's a linked gene, it's called, but you can have freckles, and black people, anybody can have freckles. It doesn't matter your hair color, of course. But freckles are something, usually you get more freckles as a kid, and then you get less of them. But some of you have beautiful freckles throughout your life too. Yeah, so these little melanocytic nevus, these little dark patches, normally you just don't worry about them, right? You take a look at it, it's not growing, it's just this little dark nevus that's there. It's not going to cause any problem. But there are really big ones. You can Google that. You see these huge dark areas, and those are more riskier, and some people cosmetically want to get rid of them. So melanocytic nevus, small, dark neoplasm, are usually not malignant. To tell if it is dangerous, this A, B, C, D, E, when you look at moles, when you look at these things, you want to be symmetrical. So you put any two sides look about the same. It can be a little off, but it's not asymmetrical, having kind of like an amoeba. The border would be nice if it's defined instead of spreading, right? And then the bigger it is, the more you have to worry. And if it's definitely, is it changing? And some people recommend, if you have a lot of these on your back or something, is you take a picture. We got cell phones now. It's easy. Take a picture, you put a quarter on there for scale, and then just do that every year. And so if someone says, is that mole growing or not? I don't know. I think it was smaller. You can bring out these pictures year to year to see changes in moles. So you take that of your body if you're really OCD and to document every mole on your body. But it's true. It's a good way because we don't know has it changed. It doesn't happen like that. Yep. So these things, you should know that. Asymmetry, border, color, diameter, is it changing? Very important to determine if it's going to be malignant. And even if they remove these things, cosmetic, it seems like it's no problem, they'll always send it to the lab. Because you don't want the nightmare scenario where you get lung cancer or liver cancer, and you're like, I got that mole removed 2 years ago, and it turns out that, in fact, it was cancerous. So now, just to cover their ass, legally, when you remove a skin lesion, the doctor sends it to the lab because you don't want to come back saying, why didn't you check that, even if it seems not cancerous. So just let you know, biopsies always go to the lab and usually comes back non-cancerous, but they want to check that. Yep. So definitely, they'll excise, do a biopsy, send it, and then they'll let you know. And if it recognize it as really atypical cells, then they'll want to look. Maybe we should look at lymph nodes around the area. Maybe we should look a little deeper. All right, malignant melanoma. This is the worst skin cancer is melanoma. The melanocytes, for some reason, when they get neoplasms, when they get cancer, they tend to go deep and they tend to metastasize, and then where they go tends to cause real problems. Looking here, I'm seeing definitely cancerous cells. That doesn't look like normal skin section. So this melanoma, you can have melanoma in situ. That means it's not going anywhere. That one's not malignant at the time, all right? And these other types, I put pictures below to just kind of give you an idea. This lentigo that I mentioned before, you see this patch, this dark patch, usually on the face. Here is a superficial spreading melanoma, the most common, where if you were to take pictures of it, you would notice that it is spreading, and it has this kind of maybe coloration is not uniform, and maybe it has the edges that are kind of look like they're spreading. A nodular melanoma really stands up, and it actually goes in deep in the skin there. Yep. This last one, acrolentiginous melanoma, happens a lot on your feet, sometimes on the toenails, and this one they want to look at too. So these are different types of melanoma. See how dark they are? Because it's melanocytes are making them. What's your survival rate? Well, if it's in situ, 100%. It's not going to be a factor in your death anyway. And then you can see if it's already spread. Look at that. 85% chance you're not going to live more than 5 years if melanoma is spread. So you can see this is a deadly one, this melanoma. And what are some things that factor into your prognosis? Of course, tumor thickness is how deep has it gone. If you can catch a melanoma when it's small and it's not very deep, you can remove it and you've problem solved. But the longer it has to grow and the faster it grows, the more likely it's going to spread. Yeah, whether it's spread, whether it's ulcerated. In terms of risk factors, it's sunscreen. Not getting too much sun exposure. Especially some of these skin lesions are bad if you're fair-skinned and you occasionally burn really bad, especially as a child. And then it tends to cause this later on in life. You may say to yourself, oh, I tan easily. I tan really well. I don't burn. I'm not going to get it. Oh, yeah, okay, sure. So what do they do about the melanoma? So of course, if they can excise it, they want to do that. And then they look at the typical cancer drugs to get rid of it. But it tends to spread to, like I say, to the lungs and liver and places, and then it's a bad one. All right, what about the other skin cancers? So the non-melanoma, they often put them together because, okay, it's not melanoma, okay, that's better, right? And so it can happen to any of the squamous cells, or to one of those basal cells, one of those stem cells at the bottom of that basal layer, right? Yeah, and so these cells, I mean, it's obviously, you know, sun exposure is a big thing. You can see one who's got it excised here. And the squamous cell, they're a little more worried about, and so, you know, they want to take it out anyway. Yeah, basal cell carcinoma, most common. You can see 99% of the time, skin cancer is not going to be that melanoma. That's good, because that's the bad one. So you can see basal cell carcinoma. It's going to begin. You can see I picked particularly bad examples here, but it can eventually ulcer out. It kind of has a kind of a raised edge around it, so it's kind of a divot in your skin, and you'll see this like in people that sailors that get so much sun exposure. Yeah, and I'm looking at here, looking at a skin section, and I'm seeing, yes, I'm seeing a cancerous cells. So basal cell carcinoma, slow growing, often be on your face. Squamous cell is, you can see here, I love this histology. You can see these like concentric circles. So those are squamous cells making keratin, like within this tumor. So that's just kind of wild. You can get this too, like say, pre-existing skin lesions. Yeah, so you can see this squamous cell carcinoma forming because you have damage because of other reasons as well. Mostly it's because of sun. And the squamous cell has greater potential to metastasize in the basal cell. So it's a little more worrisome. Yep. Yep. And how big it is going to be the most problem. All right. And lastly, organ failure. If your skin fails, you are not long for this world. All right. Your skin is protecting you. It's keeping the moisture in you, and it's keeping the bacteria and pathogens out of you. So your skin is so important for that. And nowhere is it more obvious when you look at severe burns, when you lose a lot of your skin. This happens in children that fall into those situations. Sometimes the elderly have a heating pad on too long. They've lost some sensation. They can't tell as quickly when they're being burned. Or young men making fires with gasoline, you know, doing dumb things like that. So that's where you see a lot of these great burn injuries. And in that case, you're put in an incredibly sterile place, and you try to skin graft everything you can to close up that area. So losing your skin, I mentioned burns, but it could also be from severe injuries or kind of like that road rash I talked about, where you lose your skin that way, is something taken very seriously. So. Guys, appreciate your skin. It's hard to say stay out of the sun when it's been a long Maine winter, where I want to feel some sunshine. Tanning actually gives off endorphins and make you actually feel better. Not making excuses at all. Just say you need it for vitamin D, yes, but tremendous burning and long-term sun exposure. Obviously, you're exposing this organ to UV radiation, which is carcinogen. Huh. All right, you guys. Well, hope you're enjoying a little bit of sun, and that's it for skin.